Timia, for such a wonderful introduction. Very happy to be here today. So I'm going to start by sharing my slides. If I can put them in. Okay, it's supposed to be there in a second. Okay, everybody can see them?
Yes,
Good.
looks great.
Perfect. Okay, so let me just make some adjustments here so I can see my slides too. So today I'm going to talk about the scope and about how we're creating a collaborative community of practice through a scope mental health. And just in the spirit collaboration, just want to say that I'm just representing a team. I have two wonderful social workers, Jamie Smith and Cherry Spicklick. I have another psychiatrist working with me, Dr. Samir. I also have a research assistant, Mona, and we have a clinical manager and an admin, Victoria and Jonas. And all of this would not be possible without the support of Pauline, which is the scope medical director, and Heidi, which is our primary care lead. So today I want to talk about these four things. First, I want to talk a little bit about collaborative care in mental health. Then a little bit about what the scope mental health model is. Then I will move to the evaluation, how we did it, what we learned, the challenges. And finally, we'll talk about the community of practice that we're now developing. So what problem are we trying to solve with this program, right? So the problem is quite big, actually. The world is facing a chronic shortage of trained health workers. Who gives estimates of this? About 10 million health workers, maybe by 2030. So a lot, right? Canada is not different from the rest of the world. There is lots of vacancy rates, nursing particularly, but also now there is a shortage of family physicians and some specializations, which includes also psychiatry. Also, because there is this problem with not having enough staff, there is overtime hours, which can lead to burnout. There is also unpaid overtime, and there is a high proportion of hours that people work over their usual schedules. Just want to put some nuances that that's not true for all health professions. So there are professions where people are leaving and there are professions that are increasing, right? For example, physician assistants, which is kind of such a new role. This is a profession that is increasing. And some types of nursing, particularly nurse practitioners, are also increasing. So it's not like everywhere the same. Is a little bit of an heterogeneous lack of staff. But there's also an issue of equity around not having enough staff. The first one, and probably more vital in Canada, is that people who live in rural areas move to the city and then the rural areas don't have enough people, right? So that's a problem. But also globally, that Canada absorbs people because the salaries are higher from other countries where they actually may be needed, right? And this has led to a lot of problems, particularly during the pandemic. I don't know if you guys have heard, but in the Philippines, they didn't allow nurses that had gone there for holidays to go back to where they were working because they were needed for COVID, right? So there is an equity issue both globally and locally. So one of the solutions that the World Health Organization recommends is task shifting. So what is task shifting? It's the rational redistribution of tasks among health workforce, right? So specific tasks are moved from highly qualified staff workers to less qualified that then work under supervision. And this requires a lot of trust in that delegation. So a lot of examples of task shifting in mental health are so obvious that we don't even think about it. Like social workers being trained as therapists and counselors, we accept this. I have two wonderful social workers that are trained. We don't even think about this, but this was unheard of 25 years ago, right? Same thing with nurse prescribing. And some of these initiatives are more creative, right? And I just want to mention one that is particularly beautiful, I think. It's called the Friendship Bench Grandmothers. And this is an initiative that started in Zimbabwe, where they train elderly ladies to talk to people in using empathic listening and CBT in a garden, in a bench, and they actually did a randomized control trial on this, and they found this helped people. And it helped things like postnatal depression in young women, anxiety in young women, etc. So there is a lot of ways of visualizing this task. The other part of solving this problem is task sharing, which could be defined as effective collaboration, right? So in task shifting, you delegate. In sharing, you collaborate. So task sharing focuses on collaboration between different workers in different disciplines, right? And the way we talk this, or our lingo is collaborative care. So collaborative care in mental health care is a range of models of practice. The one I'm going to propose today is one, but there are many. And the idea is that we all work together to promote mental health and to coordinate and provide effective services. But in this process, we include users, families, caregivers, healthcare providers, primary health care providers, specialists in mental health. Everybody is collaborating towards a goal. So one thing that is critical in collaborative mental health care is that you have to have allied health staff involved, because they coordinate care, assume new tasks, work on the access, gather data. They can do a lot of things. But collaborative care is not going to work if we limit it only to physicians. We have to be inclusive, and we have to include allied health. So scope means seamless care, optimizing the patient experience, and that kind of synthesizes the focus of what we want to do. We want to make sure there is a positive experience for the patient. Okay. And just to mention, scope is a program that includes other specialties. Today, I'm going to focus on my beat, which is mental health. So before we started all this, we create like a bit of an ethos of the service. So our ideas were we wanted low barrier. We wanted a simple referral pathway. We wanted interventions that were patient-led and needs-based. We were basically virtual from almost the beginning. Actually, that's not true that we're entirely. We still occasionally see patients face-to-face, but in general, our intervention is 90% virtual. We consider things around equitable care, step care approach, and we try to be closer to vulnerable populations that traditionally do not get access to services. So this is the scope mental health here at Women's. We have, it's me and another psychiatrist, and then we have 2 social workers, and the patients basically have quite close connection with social workers, and so do the primary care physicians. And then the social workers screen, triage, they also check what needs the patient have. If the need is only a psychosocial need, they address it. If they need a psychiatric consultation, then we as a team decide which patients we take. And then I see them if necessary, or they get sent to groups, or they get sent to other resources. And during this process, we communicate constantly with the primary healthcare physician. It receives reports from me if that's necessary. It receives reports at each interaction from the social workers. Sometimes the primary care physicians don't want me to see the patient, they just have a question. So we also address that on consultations with the e-consult, whatever the family doctor needs at the time. So what tasks do I shift in the scope? So, well, the social workers coordinate the clinic from scratch. They are supervised by us, by the 2 psychiatrists. They also provide brief interventions. They also provide nurse navigation. And they also provide connections inside the scope at large. For example, I had a patient 2 weeks ago who also had a difficulty with migraines. So we have headache clinic. So they will coordinate that this patient is seen in the headache clinic and then feed back to me if he needs anything, right? And the beauty of this is we've been working together as a team for the last 5 years. So we now know what kind of things are a problem for one and a strength for another, and what patients we can send where. So we created this experience, meaning that my social workers anticipate almost the questions I'm going to ask them, and vice versa. So this is just a little kind of snapshot. This was done in 2022. And at the time, we were supporting 84 family practitioners. We supported up to 105 during these 5 years. And you can see that we didn't start with 105. We started adding primary care physicians that we cover, that we offer the service to during the years, because first we were trying the system first. The level of intervention is very heterogeneous, and in this way, scope is very adaptable, but also very different. So, for example, there is people who just need a consultation. And surprisingly, that is not the majority of the patients that contact the service, right? It's about 10%. Then there's patients that may need a consultation or not, but they need support for like housing. So we'll help them with that. Or they need navigation to the service, to other services, for example, for a child or for somebody else, or they need coordination with community home care. And actually, those kind of things are the questions that we get the most. So it's patients who have maybe a mental health problem, but the problem is actually not that. The problem is how to navigate the system, and how to find the right care for the problem they have. Occasionally, we take patients for long-term counseling and case management, but again, this is not the majority of what we do. The majority of what people need is actually episodic care. So things that we do social work assessments, psychiatric assessments, brief case management, short-term therapy, psychoeducational groups, and if we have time, I can talk a little bit more about that. And sometimes we need to do in-office queuing assessments with family physicians. We used to do more of that when before the pandemic. Now it's all online, but we still sometimes do this kind of work. And then we also do a lot of indirect work, like service navigation, telephone, email, bridging support, phone consults. So what we found over time is that sometimes a family doctor would refer a patient, but really they just have one question. Can I change this medication to this? Is it safe if the patient has diabetes, for example? And if you can connect with them on the phone, you resolve the problem in 10 minutes. That's one referral that you don't need to see, because really they just need the support to make a decision. And we're quite open to that. So the Scope Mental Health is a collaborative mental health initiative, and it's a hub model, and it was co-designed initially with patients, primary care doctors, and specialists. Our objective is to keep people in the community and to support family doctors. The thing perhaps that we were very clear from the beginning is that we are not just about providing care. We want to do quality improvement, and we want to include patients, and we want to include input also from our primary physicians, which somehow are also clients. So one way in which we include this primary physician component is that we induct them into the service. And that means that my social worker will actually talk to them and say, hey, this is what we can offer. This is how you contact us. This is the information. We have an orientation one-pager. It's very well written, very easy to read. And we also have a patient handout that they can give to any patient that they refer to Scope. If they want, we can provide case examples and other things. We also have a page in Mental Health Resource Guide that is updated every 6 months, and it summarizes all the resources in Midwest that patients may be able to access on their own if they don't want to be seen. So surprisingly, a lot of people don't want to be seen by psychiatry, don't want to have any contact with that because of a stigma or whatever. But if we send them a resource guide, they navigate themselves to whatever they need. So just a note on funding. So we have a budget for it. It hasn't been actually approved for this year yet, but we hope it will be. And at this point, we have budget for what we have, which is 2 psychiatrists. We are both part-time, by the way, and 2 full-time social workers and a part-time administrator. Obviously, consultations are not covered, but we do receive a stipend because there's a lot of extra work that we do, like 3 phone consultations, steering committees, etc., to kind of bring the service to where it is now. And we've been receiving a little bit of money for evaluation. The first year we got $6,000 from a donor, which was really helpful. And then we got some slash funds on the second year from women's, actually, which was also very helpful. And then from then we haven't had any funding, but we have funding secured for a research assistant for the next year, which has been very helpful. So I would like to talk a little bit about evaluation. We think it's essential to maintain the service, to increase funding, to provide better care. And we also think small quality improvement projects can be used as a first step for something massive. And the beauty of this is that they don't require a lot of funding, they don't require a lot of organization, so you can build on that. So what we decided very early on is that we were going to do this little project and then build to something bigger over time. So I'm sure you all know about APQUID, which is a process in women's, specifically for quality improvement. In other places, it's called different ways, but most hospitals have some kind of system for that. So we developed a QA project. We passed through all this process. We got it approved. And we found some limitations, like, for example, Epic Research Model is not really, shouldn't be used for QI, it's only for research. We found we've applied to so many things to get more funding. It's really difficult to get funding on quality evaluation. It's really, really difficult. Now we have very committed staff, but in the past we have difficulties with that. And also, and this is just more kind of personal for me and the other psychiatrists, that the academic gains on doing quality improvement cannot be compared to a typical research project. So sometimes you just have to think, how much time do you have for these things? Because it's not supported as well as research. Now, so from the start, we do require, we gather all this information for every interaction we do. We have this system where we have levels of intervention because not everybody that comes gets the same, depends on what they need. And we also gather demographics and things like that. Adding to that, using the RE-AIM framework, which is a classic framework for quality evaluation, we wanted to have some numbers about reach, adoption, implementation, and maintenance. We have to think a little bit about this because we have to define what reach was for us, what adoption was for us, what implementation was for us. All these things had to be decided in advance. And in order to do that, we have some help from Dr. Pometley at WIF, who is also part of a research team. That we wanted to add a survey. And we have two different clients. We have the family doctors, which are definitely our clients, meaning that they are the ones who are sending patients. But we also have patients. So we defined two different surveys, one for the family doctors and one for the patients. And the problem we encountered when we were thinking about this survey about patients is that because our patients, not all of them get the same intervention, it's difficult to ask for an effectiveness measure. So we did a lot of brainstorming, and we include family doctors and we include our patient advisory committee on it to find the right questions for what we wanted. And we ended, this is just a snapshot, but we ended with questions like this. When I had important questions, I feel that the scope mental health program answered them, or things like, I feel this resource has provided helpful suggestions. Because really, we could not ask about symptoms of depression or anxiety because we have patients with OCD, we have patients with psychosis, we have, our patients are heterogeneous, and the service they receive from us is also heterogeneous, depending on what they need. So we think this is a good example of what we call a patient-reported experience measure, and we definitely consider it our PREM. Now, a lot of strengths, my staff is great. Like Jamie and Cherries and Ori, they're all great. And they were all very committed to do this. They understood why we were doing it. They understood that that was important. And they were great. They were absolutely great. And the thing that was a bit kind of surprising for us is that both family doctors and patients loved answering the questions. Like, they love it. Like, I don't remember our answer rate in patients, but I think it was over 70%. PCPs was a bit lower, but it still was about 50% of the family doctors we sent the survey to, they actually answered. And they kind of, both patients and doctors were happy that we were asking them questions, that we were interested in their opinion. So some results, and I only put in here the ones for 2021. We are now on a second iteration, which will be finishing in December this year, and I don't have the interim data yet. This iteration will be far more patients, so it's a little bit more complex to run. But on that period of time, which was less than a year, we got 600 referrals, 88 patients referred themselves because we allow patients to self-refer too, provided their family doctor is registered with that. The adoption, which we calculate as regards of the doctors that can refer to us, how many actually refer to us more than a number of times, was about 54%, which we consider moderate. And we can talk later about what we do to increase that too. The implementation, we valued that as cases that were seen and closed, so everything was wrapped up, was also quite good. So most of the cases were wrapped up on that period, with proving that you don't have to follow the patients forever, you just need to sort out what they really need. And then the maintenance was the idea that we should maintain the same number of referrals or increase over time in a way that was sustainable, which we found was. As from the survey, everybody was actually quite positive. So we were quite happy about that. So one of the things that I guess could hear some of the results is that the majority of the family doctors felt that we were saving time, which is very important. They also felt that the patients were getting better. They would say that they learn about new mental health resources because of us, and they will consider us before considering other pathways or in conjunction with other pathways. So we're basically the first port of call for mental health. The patients were also very positive. So we got that they felt the needs were understood, they felt the questions were answered, that the suggestions were helpful, and that we have put them on the right path to improve their mental health. So our kind of conclusion around this is that the program was well received, both by patients and by family physicians. Our adoption rates were moderate, and those physicians who used the service liked it, and they wanted the service to continue. Another thing that we didn't expect that I thought was very interesting is that physicians reported that they learn new things. Like, now I don't send you this patient because I know what to do with this patient, right? So I don't need to send you a similar patient because I learned. So there was a learning component and a component of creating capacity. And on the patient front, most of them saw the program as something positive, a step forward for them. Now, I just want to say, I didn't include all of the things that we did, but we also asked patients what is lucky, right? And doctors, for that matter, too. And everybody said, well, what is lacking is we need more psychological resources. And we worked on that, and we now have another group which works on an introduction to kind of mindfulness for emotion regulation. It's a generic group of people with depression, anxiety, trauma can access it. And we're now going to evaluate in the next few years the results of this group. And in fact, it's already been done, not only in scope mental health, but also in general psychiatry and women's. So other things that we learned, well, there is this tension or trade-off between serving more patients or serving patients with higher needs. And we're still working on that, right? So we want to keep the low barrier access to service, right? I think that's important in mental health. We can ask people who are coping with mental illness at the top to navigate a very complex referral process. You just can't. That's not fair, right? So we want to keep that, but sometimes what happens is we get patients that are too complex and take a lot of resources that we do not. On the other hand, those are the patients that we also want, because we want to help those people who are difficult, right? Who are difficult for them to get care. But we always try to maintain kind of a balance between one thing and the other. We also noticed that different practices, different doctors send different types of patients because the Like if you're a family doctor in an affluent area, the problems are very different than if you're a doctor in an area where nobody speaks English and there are recent refugees. And we're trying to concentrate on those type of doctors who are alone, who have a practice where they develop their practice because they happen to speak a second language that is what's spoken in that area, and whose patients have more difficulty to access services. But the trade-off of doing that is some of these patients need a lot. The other thing we found through the evaluation, which is not surprising, is that there's things that we can do and they're not available anywhere these days. Like long-term therapy is very difficult on OHIP these days. There's very few psychiatrists that take people for long-term therapy. It's just very difficult. Same thing with long-term psychiatric follow-up. So when we get people, for example, with learning disabilities, it's difficult to get them into a service that will provide some kind of support long-term. And also people sometimes contact us and say, hey, can you jump me on the waiting list for this program? No, we can't. And that's a hard line for us. We are not, that's not what we do. What we can do is co-manage care of complex patients so the family doctor doesn't feel it's on their own with these patients. Do proper collaborative shared care. We can give quick consultation pretty fast. I think the longest we have waiting list for a consultation was about 8 weeks. There is, depending on the illness, like patients with ADHD, I delay a little bit more, but in general, it's about 8 weeks. So it's pretty good. And we've been booking patients in less than 4 weeks, probably for most of this year. We want to keep the flow, meaning like low barrier, being flexible and managing patient and physician expectations. Just to let you know, when I mean flexible, I mean, I see a patient, we sort everything out, then we discharge them, but we don't really discharge them. We tell them during 2 years, if you need to come back. And this sometimes happens, but not that often. So most patients that once their needs are being addressed, they don't need to have so much more contact. But we keep a flexible approach. We also keep a stair care approach. So a lot of the patients of the service are never going to see a psychiatrist. They're going to see a social worker. They're going to get those needs addressed. And then if they need it, they're going to see a psychiatrist. And we're also doing a lot of education. And this education, can talk about that later, but it's not just to patients, but it's also to family doctors. What else did we learn on the evaluation? Well, we learned that there are a lot of positives. I don't know, we are now supporting 82 or 84 family doctors. I don't know them personally. Most of them I haven't met, but I've spoke with the phone probably with the top 10 in terms of referrals that they send to us. So I know what they're calling me. I know this family doctor is very good with this, but struggles with this. Or I know this family doctor is always going to contact about this issue because this is what is not available in their area and what they need. So we develop personal connections to the point that at the beginning, some of these doctors will not manage certain medications, and now they do because they know they can call me if they have a problem with that. So the personal connection is very, very important. We also learned that we need to keep things simple. And, we have an email, patients can email, and we have a phone number. And that's the best way for patients to contact it. Anything else can get very complicated for them. And also, we are flexible, but we're also patient-oriented, which means that sometimes the doctors want something for the patient and the patient wants something else. And on that struggle, we will always be with the patient, right? Some patients are not ready to make a change, but they have another problem they want to address. And what we found patients from particular communities where seeing a psychiatrist is seen like something really stigmatizing, that they come, they get one need addressed, for example, housing problems, and then 2 months later, they come for another thing. And then 3 months later, they agree to see me. So sometimes it's a process, and I think being flexible helps that process. I want to talk a little bit about expansion. So the site here at Women's College Hospital is only, it's what I direct, but the scope model has been expanded to other places in the community. So at the moment, we have 7 different sites of hubs in Toronto, mostly affiliated to hospitals, but we also have now 2 rural sites. And of all these, CAMH is following exactly the same model that we're following here, and they're also doing exactly the same evaluation that we're doing here. So I look forward to having their numbers one day, because I think that's going to be interesting to compare. CAMH started, if I remember well, in February this year, so they probably still don't have a lot of family doctors. And because we were seeing that not all our family doctors were referring to us, we agreed that they could take some of our doctors, and then we would induct new doctors. So there's been a little bit of flexibility around the model about what we do and who we will cover as family doctors. I just want to mention, this is press out of the oven. It was published last week. And this is the paper we wrote about how different sites in Toronto and outside had been changed the model to kind of fit their needs, right? And it's a qualitative evaluation based on interviews with team members. And we discovered a lot of interesting stuff. For example, lots of the staff of other scope mental health sites said that actually in their site, what they do is to learn to treat things that are uncommon, which is where the family doctors struggle, right? So they spend about a week trying to sort care for a very uncommon illness, but then they accumulate that knowledge, and next time they know what to do and what to tell the family doctor. So that in a way, what we were doing is providing care to people that most of the time would not get anything. So they talk about filling care gaps. They talk about family doctors learning and not needing to reach out for the same thing more than once. They also hope, and this is a hope, we have no way of proving that by providing more help to family doctors, that we will actually be able to increase the uptake of residents that want to do family practice. So I have the privilege of working with several fellows of family medicine and some residents of family medicine. They like the model, they enjoy rotating here, and they learn things. Unfortunately, where I haven't had much uptake is on psychiatric residents. They're not interested in this, unfortunately. And also, well, the other thing that we learned is that flexible adaptations work well. See, it's been that flexible adaptations of things work well, right? So that you have a model, but you don't have to be like kind of super obsessional about the model. If people can use the model as a baseline and then they adapt it for whatever they need, that might be actually a better option. Okay. So just reminding you, this is the model here, but these are all the other adaptations that have been done. And I only put a few, but there is, so the first one is our model, site number 1. But site number 2 decided that what they wanted was a mental health coordination and nurse navigator. And what they wanted was to do like more like navigation to community health resources, feedback to the local mental health clinic, organize nurse practitioners to receive these patients, right? And that was their need there. And there's another site where they just have a mental health navigator. The problem was navigating patients. They didn't want necessarily to do more than that, but navigate short-term and maybe some group counseling. There's other places where they have 2 mental health navigators and 1 psychiatrist, or 2 social workers, 2 psychiatrists. Anyway, each place has found what they need and use this money in a collaborative care model that is based on what we do, but might be slightly different. In fact, there is one of these adaptations is only for children, because they found, no, we're fine for adults. We want something for children. So they created a similar model that helps patients that are children. I would like to talk a little bit about community of practice. So I'm using this definition. So community of practice is a group of people who share a common concern, a set of problems, or an interest in a topic, and who come together to fulfill both the individual goals and the group goals. So how are we creating a community of practice with the scope? Well, first, we start from the basics. So I know the names of the doctors I cover, and I know what their needs are. And it gets sometimes kind of quite personal. We know when they go on maternity leave, right? I mean, we know these things, right? So there's a personal connection. So that's part of creating this community of practice. So I know if somebody's going to have a locum, that patients are going to be a little bit like disoriented around that, right? Because we know them. We also create a community of practice by having patient input. And the patient input is incredibly helpful. We have a patient advisory committee. And for example, the whole evaluation, they read everything, they discussed the questions with us. All leaflets to the patients are all reviewed by the patient advisory committee. But also all decisions about policy around the service, like recently we have to create some boundaries around, unfortunately, around ADHD, because we're getting overwhelmed with referrals. So we create a way of rationing those referrals to those patients who do not have any other option for assessment. And we created a whole screening process. And all that was, when we explained this to the patient advisory committee, we asked for their opinion. We asked for if the language was okay or not. And we have an 1 hour meeting with them, sorting out these things. And interestingly, though what we were presenting was technically rationing of care, which is less than ideal, they were very much on board with it. So I think there is sometimes a little bit of tension. Says, well, if I ask the patients, maybe they come with things that can get me in trouble. Absolutely no, absolutely not. Quite the opposite. They actually help us see what we needed to do. Now we have a patient representative. This has been very new. There was a whole selection process for that. So I look forward working with this person, but also by surveying our patients, we get a lot of input about what to do, right? We also have family doctors, which provide input through the steering committee and also evaluation services. And I want to talk a little bit about what the social workers are doing, because they're creating their own little community of practice specifically for them. And we're now also working to include community organizations, which I will talk a little bit. So, so my social workers, who are excellent, decided that they were feeling a bit isolated during the pandemic, and what can we do to feel less isolated? So they organized what was at the beginning a quite informal Zoom meeting with other social workers from other scope mental health systems around, which was good. So this then developed into, why don't we invite the speakers to talk about things that are interesting? So they defined a number of topics that they were interested in, and they found they lack knowledge, and then they invite people. And then the other part that they created is this part during these meetings where people say, hey, we're doing this. What do you think? Or we plan to do this. Or this hasn't worked for us. Or we're running a group of this, but we're not getting an intake. What do you suggest? So basically, they created this dialogue. And at the beginning, it was only social workers, but now they told me they also have some health coaches and nurse navigators that will go into this group to kind of, help each other and exchange ideas. We're working on evaluation of this initiative more than anything, because I think we need funding long term. So I want to prove that this is helpful in terms of burnt out, in terms of exchange of ideas, etc. So we can in the future perhaps formalize it a little bit more. And also, I want to investigate a little bit how social workers feel the fact that now we are all virtual. I mean, my bit of scope has always been virtual, but that's not the case with other bits. So talking about traditional methods versus virtual. We also want to develop this initiative to create more community of practice or opportunities for exchange of ideas between other allied health physicians or allied healthcare professionals who work inside the scope. And this is all called, is all in this evaluation project called Review. So representing every voice in implementation and evaluation with wisdom. And Review is about getting the voices of social workers and nurse navigators and patients about this virtual community that we're creating, and see what they think that we could do differently or better, or what's working, what's not working. And we're still waiting for funding for this. We've put our first grant in February. We haven't heard about it yet. We'll see. this is a little bit about the aims. And by the way, in the review process, we've included patients with life experience from the beginning, and we have their support to do this. Now, our other initiative is called Scope with Hope, and this is the idea is to run a wellness recovery action plan. For those that don't know what this is an initiative where people who have lived experience help other people with the same problem to do a wellness plan. So it's not based on symptoms, it's based on wellness. What do you need to do to keep yourself healthy, and how are you going to do this? There's a particular process that's been formalized and studied around RAP, and there's RAP groups in many places in Toronto. But what we want to do is expand that RAP process to communities that traditionally never had a peer support. We're partnering with a community organization called Hope and Me, or Hope Plus Me, which was formerly known as the Mood and Anxiety Disorders Association of Ontario. It's run by peers, and they're going to help us to first train our staff, then that staff to train peer people, so we can include peer representatives in certain communities. We'll probably start with the Spanish-speaking peoples more than anything, because I do speak Spanish, so it's easier for me to access this community, and because the materials are translated already. But the plan is to use it in different communities, and then we will evaluate it. Unfortunately, we put a grant for this in September last year. We haven't heard about it yet. This is a project that requires a lot of money, because obviously you have to pay for training, but also you have to pay to train peers. So it's a complex project. We still don't know when we would be able to start. If we don't get the funding, we will just do like a pilot first. But yeah, that's our way of kind of connecting with the community. Okay, I have some final reflections. The first one is that the demand is infinite. There's always more patients. There's always more things that we could do. And that unfortunately, the resources are limited. So we need to think, where do we want to use our money, and what is going to be the best way of using that money, right? The other thing is that we need new ways and new models of thinking about healthcare. We need new models, we need new things. And we seem to focus on technology, which is great, and I'm totally on board. But sometimes it's not the technology, it's thinking different, right? It's thinking differently. And being open to new ways of working is key. And this is where I think we're struggling. It's not exactly about new technology, it's about thinking different. And if it's okay, I would like to finish with this beautiful photograph. This is two participants of the Grandmas in Benches program in the park that I mentioned in Zimbabwe. And I think it's a beautiful example of how thinking in a different way is as useful as technology. This is a very, if you want, rudimentary intervention, but it helped people. It helped people that did not have any other outlet for their problems with mental health. And I think this is what we need to think about. We need to think about new ways of thinking as much as technology. Thank you. I don't know if there is any questions. I think I actually did 47 minutes. I wasn't too bad. I'm happy to answer anything.
Thank you so much, Blanca. That was wonderful and very interesting. I really liked your last point about thinking a different way, being creative and innovative. Okay, we can open it up to some questions. Taking a look around. I see Rulan physically raised her hand. Please go ahead.
I went old school and lifted my hands. I wanted to ask you, Blanca, so the approach that you went through was, partly driven also by COVID and sort of what was needed. So if you wanted to start the program again, what would you do differently, and how would you approach it sort of in a different way, when you weren't forced to suddenly be able to do things virtually, how would you think about doing it?
I will change everything.
Everything. Okay. All right. Well, tell us
beauty
the
of
most pain points. Yeah. Tell us, what do you think would be the perfect way to do it then?
Okay. So the first thing is, I think I would have started technology-wise. I would have started with a system that, like an EMR, that everybody had in common. Because the main problem we have with all this is that we're still using faxes, right? Because family doctors will use one, we use another one. My social workers are based at UHN, so they use a different EMR. That we haven't sorted out. So I would start with maybe a new system where they just log in and everybody's on the same system. This has given us endless problems, right? The other thing is having a system that is common for family doctors, me, and patients that they can reach means that the evaluation would have been far more easy, right? We're still faxing some of the surveys. We have to fax to doctors because we didn't have emails, we didn't have anything for them. We're not going to call them on the phone. So, and I think the evaluation that we gather data almost from the beginning, I think we could have been, perhaps we were too scared and we should have been more ambitious there, right? Now, the virtual part came very natural to us. So I don't think I have any regrets on that. Though, of course, you can always have like a virtual platform that is better or worse than others. I still use OTN and Zoom through the computer in women's, but it would be nice to have platforms that you could do more things with them. So that's probably a thought. But then the more complicated the platform is, it's also more complicated for the patient on the other side, right? So you also need to consider that. I think those would be my main caveats.
I guess I just ask a follow-up. How would you, so we have the very specific program, but how do you scale and spread that across the province? Like, how do other places sort of replicate what's happened?
Yeah, so we've done a lot of outreach, so we can talks everywhere. And we also have a toolkit that is on the website, on the Scope website, where we explain how you start this program from scratch. Like literally, we share all the information about how to induct family doctors, we even have a job description for the social workers and your nurse navigators. And that's all available for everybody that wants to read it. And the toolkit goes from starting the program, like hiring people, what model you want, why are you doing this model, learn more about the model. We are using the Washington model, so they can go to the website and read more about that. Up to the point, these are the case scenarios that you may get. These are the things that you can do. Are you considering this, right? So it's all there. It was written in 2022. It's just now become available and that also has a webinar. Unfortunately, the lecture is not there because they lost the video, but it has all the slides explaining everything up and down. So you can read the slides on the webinar and then go to the toolkit.
David, please go ahead.
Thanks, and thanks, Blanca. That was an amazing presentation. I'm wondering if, you've done evaluations of the program and sort of drawn insights and, lessons learned. To what extent have you thought about, or are you even able to use, information about patient treatment? So, standardized measures, PROMs, other measures of treatment outcome to feed back into the program as part of the cycle. And the reason I'm asking is this is sort of, part of the direction we're looking to explore is how to complete that cycle so that we're not only learning generally from the program, but also sort of every patient, every piece of data potentially can be, something we can learn from and can inform future care. And, so every patient is sort of, we're learning from every patient. So like, what opportunities do you see, given the structure that you have in this SCOPE program, but even more broadly in your use of PROMs and standardized assessment tools? And, is this something that's come up or that you've been thinking about?
Yeah, so this is how difficult it is when you have a program that can be adapted differently, right? So we actually had a student doing a review of proms and prems for us for 6 months. And our conclusion was nothing out there was heterogeneous enough to cover our patients, because we don't see patients only with depression. We don't see patients only with anxiety. We see patients that may not really have mental illness, right? So it was very difficult to find a prom that fit that. And that's what we set them for a prem that we actually trialed ourselves and have to create ourselves. So I think this is one of the problems of collaborative care, is that a lot of measures that you use in other things, particularly mental health, do not work well because you're adjusting to the level of the patient care, right? So I can ask to the patient something like, did your depression improve? When what you did was actually get help to get food delivered to your home because you cannot get out because you have a small child. And this is the problem. And we grappled with this for about 6 months to a year until we found this kind of, well, we're going to go the prem. The prem has worked very well for us, and it's now being used in other sites, but we probably need more than that. I do agree on that. But it's difficult to find a patient-oriented measure when the outcome and the ask is so different from one patient to another. So that's why we created review, because what we think is a better method to do that is to actually invite the patients to talk to us, right? And get them all together and see what things express to that, which is a very different way of thinking, because I'm trained as an epidemiologist, so I want numbers, right? So, but you need to think that in this kind of collaborative care, the numbers are going to be the number of people who go in and out, but when you get to prompts and things, you may be best served from a qualitative perspective. So it's a very different way of thinking.
Any other questions for Dr. Bolea? Great. Wonderful. Thank you so much. Thank you so much, Dr. Bolea. We really appreciate, learning more about this initiative. And I think, it really is in line with, collaboration, everything we're trying to build with this learning health system. And just around evaluation, really getting into that culture. So yeah, if there are no further questions, thanks everyone for joining. Blanca, we'll see you in a smaller meeting just following the seminar. Thanks, everyone.
Thanks.